Thank you, Dinesh, for having Dinesh Garg for having me for the symposium, and a happy birthday again to Dr. Talwar. So I'll be talking on the options and advantages of ultra wide field imaging. Of course, no financial interests here. So there was an international wide field imaging study group comprising of 11 retina specialists who evaluated the set of seven images, and they were limited to images, and they tried to define these words, these terms. And wide field angiography would be limited to images that could take all the four vortex ampullae in one shot, while the ultra wide field image was one which had the image of all the four quadrants beyond the vortex ampullae. The posterior pole was the area of about 50 degree, while the mid periphery was the region between the posterior edge of the arcade up to the vortex ampullae. And a pan retinal image would be an aura to aura image as seen here by these um, authors. So we have this in from this article: a 20-degree field, a 30, a 50, and then these seven fields which give you about 75 degree, and then the red cam which gives you about 130 degrees in one shot, and then the Claris and Spectralis which give about 150. So this is wide field, and then the Optos which is giving you a truly 200-degree ultra wide field image. And this has been recently, the various options have been discussed in a recent article this year in IGO as well. So this is what would be a 30-degree or a 50-degree field. And what is important is that when you have an ultra wide field photograph, you're actually getting to know what is happening in the mid periphery, in the periphery, and at the center. So you have got CNP areas over here, and you've got non perfusion, and there is macular edema over here, and there is retinal vasculitis. So you can put two and two together in just one image, and you can have all the images, all the features in one shot itself. So this was a conventional angiogram, and it missed a small NVE which was picked up in on the ultra wide field, and quickly you can confirm it by the conventional angiogram. So now we know that diabetes is not just mid peripheral disease. There is peripheral ischemia as well, as Sangeet had shown earlier in one of the his slides. And you can have an NVE beginning outside the mid periphery or juncture of the mid periphery and the far periphery. So traditional photograph would give you 30-degree and a 7. This is why we use the seven fields, because the NVEs are located in this seven field. But what actually is happening is the CNP areas are located outside that. So the effect is located inside, but the cause is outside. So that is why it is important to get your ultra wide field image to know exactly where the ischemia is. And you can actually miss those very early NVEs even in diabetic disease. In vascular block, there is the concept of the ischemic index. We know that we used to talk about disc areas when we were talking about development of NVD in CRVO. But what you actually do is to quantify it. You can actually calculate by the pixels of non-perfusion and the total area of pixel, and you have the ischemic index, and there is a 30% ischemic index. And what is important is that it shows that when there is non-perfusion in the periphery, it causes both neovascularization as well as the macular edema. And that is what Sangeet had earlier said, the concept of treating the peripheral with peripheral photocoagulation in cases of vascular occlusions and diabetic retinopathy when there is a resistant macular edema in these cases. So here is a CRVO, or rather I would say venous stasis, and you have these CNP areas over here, and the late frame is actually showing you the development of macular edema and disc edema. So whether this is related or not can actually be seen after you do the laser treatment to these areas. And here is a Hemi Crvo, and you can see the large confluent areas that require immediate treatment to prevent neovascularization. And the ischemic index here would be as high as 70 or 80% in these cases. So the ischemic index has been really helpful, and when the ischemic index is over 45%, then the risk of neovascularization increases considerably, and when it is below 6%, then the risk of neovascularization is almost nil. So this is a patient who has got neovascularization of the iris, and you do a conventional angiography. You see a little bit of a leak here. Yes, there is some neovascularization of the disc, but where is the ischemia? And when you do the ultrawide field, even through those small pupils with neovascularization of the iris, you can actually delineate large areas of peripheral non-perfusion, and therefore, an targeted laser treatment would help in regressing the neovascularization of the iris. This is retinal vasculitis. So, in retinal vasculitis, you get two things from the fluorescein angiography. If you see the staining of the walls, you know that you're dealing with an active disease, and if there is a peripheral CNP areas, then you are getting a neovascularization. So this patient has actually developed a small neovascularization while the disease is coming under control, and we've actually done exactly laser only to that area which is showing on the ultrawide field, and you can see that the neovascularization has regressed, and we have saved the peripheral field by not doing a pan-retinal photocoagulation, but treating completely the CNP areas that you see in retinal vasculitis. We have been talking about safety of fluorescein dye, and I have done a very large number of angiograms. I've come to the conclusion that if you decrease the dose of the dye, definitely the side effects come down. So when I have a patient, when our machines are improving, we are SLO based, why should we give the standard 3 ml? I've come down to giving 1 ml or 1.5 ml, and you can see that you get an equally good image, in fact better image, because the leakage of dye is lesser, so and your machines are so much better. So you are going towards a low dose angiography when you have got the more sensitive systems. And this is an SLE with kidney disease, and you got the neovascularization here, which has been beautifully seen here. And this is a case of sickle cell from the major review in survey, and you can see the uh, neovascularization elegantly in this patient with sickle cell disease. So, ultrawide field, is it really useful? Is it indispensable? And what are the special situations? So, myself and Drais, our group, we were the first to do a angiography through an air bubble, and you can actually see that the conventional angiogram shows reflecteds, and you actually don't get anything in the air bubble. But when you do it through the ultrawide field, because it's an SLO based system, and the source of the laser is a pseudo source within the eye, you can actually take the image through the gas bubble. So we were able to, this is a 2016 publication of angiogram in a patient who had who had surgery for proliferative diabetic retinopathy, and we could see the retinal status. These are very small pupils. You don't know what is really happening, but when you do the angiogram, you can see that it still requires laser augmentation. Far peripheral lesions, like the angiomas Prashant had shown beautifully, can be delineated very beautifully by a ultrawide field. This is an inappropriate laser because it's an inappropriate angiogram, and you can see that the neovascularization is persisting in the periphery, and this is an indication for a repeated angiography. So this is called in check FFA. You have done the panretinal photocoagulation, and then you look for any hidden neovascularization, which you can see here. So pediatric cases, of course, there'll be a talk later, but you can see that this girl has got an abnormality here, and the fellow eye has got paving stone degeneration, and this is probably a congenital fibrovascular proliferation in the periphery. And children are very happy with angiography because they don't have the flash, and you can actually do angiogram very easily in these children. you can see the picture, you can see that there's retinoblastoma, and you can put two and two together with a wide field image that there is a seedling that is happening, and you can have a timeline on the lesions as you have in ultra wide field images, and it was proven here. So you can do FFA even in ROP, and this is again another ROP which we published in 2016 in the Indian Journal of Pediatrics, where we have shown this is a montage image. So in a child with a flying baby position, you can't really get the images so beautifully. So you can put two and two and get an image very beautifully there. So I would conclude by saying that it's a comprehensive, elegant technique, and special situations would be non-dilating pupil. Missed lesions are less, and it gives you a more accurate angiographically guided treatment, and it is indispensable in pediatric imaging. Thank you very much for your attention.